efforts, which, like I mentioned earlier today, we have the NAMRU in Peru, the one it used to be in Cairo, but I think after the Arab Spring, like in 2016, I think they changed them, and the one in Singapore. So they're all over the place. And we have some here too in the States. Aberdeen, there's one at Fort Detrick, Maryland. They're all over the place. Slide. And the CDC, actually. Duties and responsibilities in the Navy Medical Department personnel. It's going to be found in Chapter 2 and 22 of the Preventive Medicine Department. I always remember Chapter 22 because after you turn 21, you're out there and you got to go see Prev Med. Get it? Cool.
STD's got it.
As required by the ManMed, senior medical officers or SMO at every command must ensure their command has an adequate policy, which we do here, on the effective times of reporting. So a lot of the policies were amended due to COVID, because COVID was very specific as how they wanted it, and then they just said, out the window, no more. But every command is supposed to have their policy overall. So the ViewMed instruction gives you the guidelines, so the policy is built on the ViewMed instruction. Cool. It basically works like that everywhere. Slide. So medical event cases, finding the surveillance, search for any unreported events. Threat medicine personnel, MTFs, and branch clinics, we're required to actually have access. I'm actually one of the SS accounts holders, and my EHO is the other SS account holder. So I would remember that one, and I would write that one down. The electronic surveillance system for early notification, community-based epidemics, ESSENCE. So what that is, and there's a slide coming up here that actually shows what it looks like, is everything that was done previously in Alta and also into now Genesis. If it's reportable, I'm talking like gunshot wounds, traumatic events, violent events, cold like winter illness. So like last year when we had RSV going on pretty crazy, all that stuff gets reported into ESSENCE. It actually feeds into ESSENCE, and then we can see trends as to what is actually like potentially coming up, kind of like that. The epidemiologist, Asha Riego de Dios, she is phenomenal and insanely smart. Yeah, she works upstairs. She is amazing. Helps out a lot with this location.
Don't confuse this with DIRSI. What's DIRSI again?
Oh, DRSI, the Disease Reporting System Internet.
Right, so the way they're going to word the questions, they're probably going to put both of those systems as answers.
So this was going to be surveillance, and this is going to tell you of any potential trends, right? DRSI is where we actually submit the medical event report.
You said ESSENCE is for keeping track of trends?
Yes, trends. And it requires special access because you can actually see everything that's going on in there to the actual encounter. So like if somebody gets shot, right, we can actually see in there that they suffered a gunshot wound. So it requires HIPAA and like a few other things you have to be vetted for.
So that last sentence should be highlighted in red too. I didn't notice until now, but I've seen it as a test question. It's going to ask where you get guidance for reporting, interpretation, and you just went out of the slide there. Reporting, interpretation, and response to fleet DNBI information. They're going to say where you get guidance for DNBI information. It's going to be NMC PHC.
Basically everything that has to do with anything that's 62,000 series, 6200 series is upstairs. Public Health Center. All those people up there with their big sexy brains doing what they do for the rest of the Navy. If you're in an operational command, you should actually look at the binnacle or the actual SIG call log, so you can actually start making your own trends. If you're at a ship and you have access to a computer, or even in the field, you have one of those field computers, it's really easy. You just have your sign-in logbook and go to your computer and you start putting in. These people showed up for this kind of illness. They had alcoholic diarrhea. This person had welts on their back. And you just kind of start going there and you filter, so it kind of helps you find out what is actually happening more. So you can get really primal, like a very basic understanding of Excel will help you with like being able to track. So even if you don't have these systems, having something like that, at least at a very minimum a logbook, that will actually help you track. Slide, please. Whatever you guys can. We got it. 1 second. Sorry. We now return to regular schedule. Slide. Next. Yep, next. That's what it actually looks like. So that's when you start seeing your trends. They're based off of weeks. A lot of our reports are done year first, so we can actually keep track of them. You'll see like 2023, 1203. So that's December 3rd, 2023. Because a lot of these reports have to be reported within the weeks versus the actual days. Once you actually, like let's say you go to 2023, 22. That's your 22nd week of the year. So you're talking probably mid-June. Click on a little dot. You can click on what was up there. And this one right here is just a screenshot of everything, the entire thing that's on there. So like STIs / STDs, violent traumatic events, reportable like respiratory things like influenza, the few malaria cases that we had here, traveler's malaria, it's not here. Things like that. Like this is how we can start seeing. And when you actually open it up, it lets you see everything for every installation in the world. So it's a lot of information that you're given on that one. Slide. Reporting requirements. Any diagnosis, case, or medical event that has been identified in the DoD healthcare beneficiary and classified as reportable shall be reported. So anything that's in that list that I gave you, or the one that you guys should have right now, which is the one that was published recently by Navy Marine Corps Force Self-Protection Command, that has to be reportable. RMEs, reportable medical events, are to be reported by the medical officer, command surgeon, to designated staff responsible for the healthcare and treatment of the individual. So if a provider sees somebody and if they come back with a reportable disease, they're supposed to let the individual know. That's not preventive medicine's job. We do it if they don't actually know. So like, for example, if somebody gets seen for an STI, and if the policy at the command is not to treat first, when those lab results come in, it populates on DRSI, and then we have to go in there and, hey, how's it going? This is Fayos Martinez from Preventive Medicine. Just letting you know, your results came back, you have chlamydia. Have you been treated? No? Okay, then I would reach out to your, it's really awkward conversations, but not really, because I don't have it, so it's not really for me. Research lab that identify a case, medical event sufficiently enough to classify it as reportable should report their findings to the cognizant NEPME. So for this hospital, the branch clinics that we have here all the way down to the North Carolina border, and even actually all the way down the East Coast, the NEPMEs review this. And if there's something that's incorrect with it, like it's actually supposed to be probable and not confirmed, they'll flag it and we'll get it back, and we're there on the computer all day just knocking it out. So it's a lot of work. Slide, please. Think of it this way. MTF, NEPMU, Navy Marine Corps, Force Self-Protection. Because they're the ones that have the policy, right? So they're the ones that know everything, because that's their job. They do policy. This looks a little bit familiar because I brought it up yesterday. Diagnosis of the case, reportable medical event classification. So a diagnosis of the case, medical event becomes reportable once it's been classified as suspected, probable, or confirmed. 3 different types. This is the second time you've seen this since yesterday. Clinical laboratory epidemiological criteria must be met. So when you actually, I couldn't open it up and show you what it actually looks like because of HIPAA, right, and PII. But every single one has a template similar to how Alta used to work. So if it is a chlamydia, it'll say, hey, it's chlamydia trachomatis. How was it actually found? Was it the urine sample? Was it the NAAT? How was it? And you have to actually put that information in, and it gets cross-referenced to make sure that that's actually what's being reported. Reporters are going to find the detailed criteria in what we studied yesterday. Conditions of required medical event report for either suspected or probable cases are listed in Appendix C, which is the exact same thing that I gave to you guys yesterday. Cool. Slide. Yeah, you get pinged a lot if they're not confirmed. You just keep getting the notifications. You got to work on them. So it makes for really, really long days and a lot of uncomfortable conversations with people, especially when they answer the phone and they're on speakerphone. Outbreaks. So outbreaks are disease clusters. They're defined as any occurrence of a medical condition that exceeds a baseline or expected rate within a place or group of people over a period given of time. So the understanding is that there is going to be illness, right? So you can expect if you have 100 people, let's say 10%, whatever the threshold is for whatever disease it is, that many people are likely to get sick. Once you go past the 10%, you have an outbreak. And I'm just using 10% arbitrarily here. It's not like an actual number. It just depends on the actual type of disease that's out there. Some cases, a single case may constitute an outbreak, depending on the organism. So smallpox. If there is one single case of smallpox that's confirmed, that's considered an outbreak. So anyway, I would remember that one.
So not suspected, only if it's been confirmed.
Even if it's probable or likely, it's considered an outbreak. You have to investigate, and we have to close the loop on that to make sure that it's either A, confirmed, or it's not. And contact investigation and tracing actually is where it expands and goes further into that. It's a lot. The decision to report an outbreak requires professional judgment. You can't just say, this is an outbreak. We have 5 people that have norovirus. No, you can't just do that, because what happens when you say that you possibly have this or that? Fear. Right? A lot of fear, a lot of distrust, a lot of I don't know what's happening. And now, because we live in the world that we live in, I joined them when MySpace was still a thing. So, you post something now on Twitter or Instagram or anything, everyone knows. Everyone knows immediately. So the water stuff I was talking about, so a third-party tested water out in Oceania, which is not authorized, and PFAS was found in the water. So runoff from chemicals and stuff. You probably heard it in the news quite a bit recently, and that's a big no-go because it's a PAO issue. And I can talk about it because it was actually in the news. So it's kind of messed up. So you really kind of have to figure out what it is going there. So any illnesses causing rapid rise in numbers of affected people, so how fast it's actually transmitting. Any illnesses that are actually hospitalized or people that can't actually do their job. If it's limited to a specific group, demographic, occupation. So one of the reportable events that we had was heat stress, right? So if the only people that are getting heat stress are your Lance Coolies that are building HESCO barriers by hand because you're making them, yeah, there's a problem. That means that, maybe you shouldn't be using all of your E3s. You know what I'm saying? So you really have to get very specific into what it is that you're looking for. Highly infectious or virulent organisms, so norovirus moves really, really fast. Within 24 to 60 hours, it can literally bring down the ship immediately. And it's so really hard to find out if it actually is or not because, again, you require a stool sample. But you kind of get the idea for that. Illnesses that may prompt an installation commander to exercise public health emergency powers. I'm the secondary for that here. We don't really do a lot with that, actually. But illnesses that are indicative of public health emergency or acts of bioterrorism. So if somebody were to make Clostridium botulinum, so botulism, and weaponize that would require a public health emergency. COVID was considered a public health emergency. RSV was almost considered a public health emergency. When I was stationed in Bangor, Washington, we actually almost made syphilis a public health emergency because the rates at which Kitsap County was getting syphilis, it was a problem. Because you also have to remember, these people get treated, right? And that costs money. So that's just waste going on. Maybe not waste, but when you submit a report, the thing to remember for this one mostly is that you only submit one medical event report per outbreak. So if you have 2 people with smallpox, you only submit 1. That's it. Yes?
This be similar to that. Well, what was going on? Was that in Florida when they reported somebody had a leprosy or something like that?
Leprosy, that one, it would have to be more people than that.
Okay.
But it depends on what's endemic in the area or not. Florida's just an entire thing.
I ain't trying to get off the subject or anything, but this just has me wondering.
No, you're fine. So with that, it really just depends on who the public health emergency people are there. So every state has what they call the Department of Health and Human Services, and that person is typically a PhD epidemiologist that says, hey, this may be a problem. It's a lot of math, and chi squared, and But I went through it. I can still do it now, actually. Slide, please. All right, this is a really big one. This is actually one of the things that I updated from the previous slide. So it wasn't updated to the previous slide, but I updated it to the actual thing. I would write down everything that's in red. For those of you that are out in Microsoft Team Land, we'll be sending this slide out because the dates are a little bit different than the previous slide. So reports can be either urgent or routine, two different types. Urgent must be submitted no later than 24 hours after the event has been identified. Routine are to be submitted no later than 7 calendar days after it's been identified.
Previous slide had 30, so just know that's what the change was.
Yeah, previous slide was 30, so it has been updated. The 30-day window still technically applies if it's very, very minor, or if you don't have the capability to submit an urgent MER, or MER, as we call it too.
Is the 30 days if like the system's down?
Yeah, or if you have to send it via message. Or,
Okay, that makes more sense. Okay, does that make sense to y'all? So normally, when a system is up and running, you have 7 days for request. Now, say the system's down or you're having troubles actually getting a message out, you have up to 30 days to still get that message out if it's by priority naval message or whatever it is, to still get that time frame. So the time frame extends if equipment is down.
Yeah, well, it was TMIT and a few of the theater systems that we use where they actually send messages that way, encrypted messages. Even if, like, let's say we're in, I don't know, where there's conflict going on over in the Mediterranean right now, you're still required to submit these reports like immediately. Typically, your preventive medicine technicians, environmental health officers, entomologists are going to be at headquarters. You're not really going to be with a line company unless there's not enough people, and then you're 8404, which means that you send in rounds downrange. Events which require urgent reporting are outlined in Appendix C in the handout that I gave y'all. Right? Handout that I gave you on the bottom right gives you the exact information, 7 days and 24 hours. Cool?
So advancement exams, for some reason, on this manual and your IMS manual, love to ask you which appendix is what. So I know it's not highlighted in red, but I would know like the really standout appendixes, because I know, and I don't know if y'all seen it, those have been test questions asking what appendix does this certain category fall underneath.
The dates, time frames, I would really, really remember that. And I actually want to say that depending on the type, and this is the correspondence thing, but depending on the type of message between priority and routine, it's around the same time frame. So it's like a priority or urgent message, enable message, it's got to be within 24 hours. Routine messaging can be sent out via enable message at a much slower rate. Same thing for Marine Corps correspondence as well, because they use the exact same thing. Slide. Slide, please. All right, this was brought up a number of times. The Disease Reporting System Internet. It's the official system for us to submit, view, and track MERS, or MERs. I would write that down. You may also see it as NDRSI, which is Navy Disease Reporting System Internet. Because this is a Navy exam, I would see both. It's probably going to be listed as NDRSI. Our system is still called NDRSI, but it is a tri-service system, which is now owned by DHA. Really write that one down.
What was that key word to know the difference? What was that T word you used? Trends, right? So trends is going to be for essence, and this one's just for regular reporting.
The actual MER. Essence has been on the advancement exam before. That one, I know that I've seen it on there a number of times, actually. Another way to remember this too is that DRSI is for disease non-battle injuries, DNBIs. So that they may ask you that question that way as well. What system do you actually use to report DNBI, disease non-battle injuries? The disease reporting system, because it's not an actual battle injury. So like an actual GSW or traumatic event or things like that. Preventive medicine technicians permanently assigned to shore-based MTFs, like this one, are required to have an active account. I have one. All the PMTs up there, including our PMRs, actually have an account. Within assignment, you're supposed to have it. and they change it. It's universal, so as long as you enter your information, you can actually go to a different MTF and just upload the stuff as needed. Anybody else can submit an MER by DRSI if they have it, so IDCs can get it as well. Quad zeros can get it as well too, depending on your capability or assignment. By phone, naval message, or email to the nearest NetMU. The NetMU is manned 24/7, even in inclement weather, and they will get you to the right person as far as they need to. The other people you can contact as well is going to be the Public Health Center, which is upstairs, but I'd go to the NetMU first, because again, you go from MTF, BAS, whatever, or roll 2 or 3 to the NetMU.
Do you guys know all your NetMUs?
So we went through it a little while ago.
Okay. Definitely been on the test a couple times.
NetMU 2 Norfolk. NetMU 5, San Diego. Hopefully I get those. Cali Bees, man. Can't wait to get me a Cali Bee. California burrito. Okay. With internet connectivity is limited, reporters may use the 7-day reporting window for non-emergence, but you still want to try and get that as fast as possible by radio communication, I don't know, smoke signals, I don't know, whatever you can do to get that information out there. The urgent one is still priority. You have to do whatever you can do, sat phone, like whatever, to get that information out. Most PVs or even patrols, they actually have a satellite phone assigned to them, so you need to make that call. People call home all the time in Afghanistan and the overseas, so we can still do that. So where there's a will, there's a way. We do have sat phones for that reason. Operational units in a command directed communication condition that prohibits that. So River City, you just have to delay them. So if it's an urgent report, so let's say end of 2012 when Bastion was attacked, we were in River City for like a month, and nothing was going in and out. Supplies, nothing. So if you had somebody who had something that was reportable immediately within 24 hours, it didn't go out. You just had to treat them symptomatically or specific as to what they had to be treated on by the Communicable Diseases Control Command Manual, or whatever you had. Couldn't do it. So it's all to maintain your tactical integrity. But that's what it looks like. Again, I wanted to get in there and see if I can get some training slides from that, but it's not available, so I wasn't able to get that, get those slides in there to see what it looks like. It's a lot of people's PII, infants, adults, beneficiaries, everyone. So I'm sorry I couldn't do that for you. But if I can find a way around it, maybe get a blank one, or maybe just do it on myself, then I'll see if I can put that in there for you. But I got to get clearance from the big guys upstairs. Slide, please. In general, medical reports are considered unclassified. I would write that one down. Unless the officer with appropriate authority has classified it. So just like with any kind of classifications, when you do the CUI stuff, it requires somebody who has that level to grant it being either classified, sensitive, or not. But it is unclassified. Because the point is to get it to the NetMU or to DRSI as soon as possible. So you got to do what you got to do, right?
You know why that makes sense, right? I like to try to make sense of these so you're not just trying to study something. Why do you think it's so urgent to get these quick? What is the whole point of this instruction? It's about disease outbreaks.
We can get ahead of it.
Right. So can you imagine if we waited forever to report COVID? Then it would have been an even bigger outbreak, right? So that's why they have that quick 24-hour time frame for anything that's breaking out tremendously, to where it's not going to, they want the public to know. That's why it's unclassified, so that they can go ahead and start protecting themselves from whatever that outbreak is.
Yep, it's a very good point, actually. Because, like, think of, I want to say plague is in there that's reportable within 24 hours, I believe. You could be at a training, just like I mentioned yesterday, you could be a training exercise over in Wyoming, Cheyenne, Wyoming, and your people that you're with are getting plague. Those little buboes start showing up on their skin that are black in the center and red on the outside. I wonder what that is. Maybe I should let somebody know. It doesn't matter who finds out who they are, just get that information out. That's the whole point of this. Any MERS or MERs that contain any sensitive information, they all do. Because you have your age, sex, gender, I believe now it has gender identity, social, EDIPI or DOD ID number, contact information, everything. What you have, how it was tested, everything. So you should safeguard it as much as possible. Digitally signed and encrypted, that's pretty basic, right? We all have to do that anyway. Maybe not encrypted, but at least digitally signed. And if it's U.S. mail, which is what we send everything on paper with, marked for official use only. There are certain carriers that do the things, but I'm not going to get into that because there are like bugs we have to send a certain way. Slide, please. The Nephews, as mentioned before, are the Navy's primary direct providers of the following consultative support services. Reportable medical event confirmation assistance. They literally have laboratory techs, they have epidemiologists, they have entomologists, they have preventive medicine officers, PMOs, which are physicians. That's all they do. They train and they do research, and that's all they do. General support, public health lab support, so they have their own AMOL, which has everything. They can set up an actual like field laboratory and like collect things and figure out what we actually have. Outbreak response and epidemiological study design, so if you think you have something, they can help you with how to notify the people. Disease surveillance and MER training, so they, for us specifically, whenever we have to do our training for our licensing and upkeep, we just go to them, and most of the time it's done by Public Health Center, but they all work together. Their Public Health Center is their parent command.
I want to phrase that as a test question for y'all real quick, because that's what I've seen on the test. On the test, it'll say, who is the primary direct provider of the following consultative support? And it'll probably mention that last one about disease surveillance and training, right? And it'll probably put on stuff that sounds very similar. It'll put PrevMed Tech, it'll put NMC PHC, it'll put NavPrev Med N2, whatever the hell it is, and
NetMu 2 or
it'll have NetMu, right? So you need to know that's how they're going to phrase the questions. On this chapter, they want to know who is the primary person to go to, because this is all about guidance on who runs these specific areas, because for PrevMed, they have to have some overarching guidance where they're getting information on how they're going to delineate it to the services.
Yeah, they're your SMEs across, wherever side of the world you're at. They're going to be your SMEs for all of that. They can be reachable 24/7. Just like listed on the list that I gave you, this is Appendix C. So reportable within 24 hours or an urgent report. Anthrax, botulism, diphtheria, hemorrhagic fever. So like as you saw yesterday too with HM1, I can't remember her name. Crimean Congo hemorrhagic fever, which is like actual like Ebola, Eastern equine encephalitis, all those things. Like, they're all in it. They're reportable within 24 hours. Malaria, so like when we had our malaria, the 2 or 3 malaria cases that we had here, we had to report it immediately. Because it's, even though it was travelers malaria and they didn't, like, it doesn't spread from person to person, we still had to report it because it was an active duty member who had malaria and we had to report it. It's simple, right? And it had to be within the 24 hours. So as soon as we got that notification, had to send it out. Confirm what it was, what plasmodium, falciparum, which I think was falciparum, Vivax, all that stuff. We had to send that up immediately. Measles, meningococcal disease, outbreak, any outbreak of disease cluster, obviously you send that in immediately. So like I said, 1 smallpox case, that's a disease outbreak, 1 NER. Tularemia, tuberculosis, smallpox, SARS, so like the Asian SARS, or the, I think MERS also goes into that, which is a Middle Eastern respiratory issue. Any rabies case has to be reported immediately. Polio, plague, so Westernia pestis. These are your other ones that can be reported within a longer period of time. Hantavirus, heat illnesses, these could be extended to the 30-day mark, but you want to report them within 7 days. So what are your 2 main time frames for urgent? 24, 7. How long could it be? How long could a routine would be stretched for? 30 days. And what is the only condition that you cannot report a 24-hour one? Like, what is the only thing that can prevent you from reporting an urgent report?
Your commands in some kind of officer.
Tactical operations, River City, right? Those are your other ones. So those are your leprosy one. It can be reported, but it's really not endemic to here. Yes.
Last year, I know monkeypox was a huge thing. That was like a small outbreak,
Yes.
but it's not on this. Would it still be considered an outbreak disease cluster?
That one's handled a little different. Kind of handled the same way with HIV is. And it hasn't actually been updated because I believe that one was updated in 2020 or 2023, something like that. the date should be on the front. But it's based off of that manual, and the manual, which is the Armed Forces Reportable Disease List, wasn't updated since 2022. So they haven't put that one in there yet. And I don't think the CDC has actually given out guidance for that. That's what we're supposed to do. But it is something that we do report, because it is, when you actually get into the system, it is in the monkeypox. Yes?
The list you gave us yesterday included COVID. Is that covered under SARS, or do we report it under something else?
COVID. COVID is its own thing. SARS is different because that's the more the Asian one. COVID is its own thing.
So is that a 24-hour then, or is that a...
No longer 24 hours. We don't need to report it.
Okay.
Yeah. There's some tomfoolery that happened with some of that reporting that I'm not going to get into, but I'm just going to say a lot of reports were to people. Slide, please. More of your stuff is going to be within the 7 days, 24, or up to 30 days. Yellow fever, varicella, things that are not highlighted red in the sheet that I gave you guys. Slide, please.
I think that's the last slide.
Look at that. There it is. What